Hello, my name is Elaijah Lapay, and I am an undergraduate rising sophomore at Duke University. This past summer, I have been an intern for the Duke-Margolis Center for Health Policy, and I've been working directly with the Center for Policy Impact and Global Health, led by Drs. Gavin Yemi and Osondu Ogbuwoji, who along with Dr. Wenhui Mao have served as my mentors this summer. In addition, my particular project has led me to work directly with the Community Partners International, a non-governmental organization based in Yangon, Myanmar. I have worked closely with Dr. Zinmar Win and in-country collaborators Zarni Lin Kya and Tom Trail. Now, to provide some introductory context to this project, there's been a global trend in the rise of non-communicable diseases with increasing quality of life, especially when looking at countries with low and middle income status, which Myanmar achieved in the mid-2010s. Now, this project aims to investigate more into the comparative costs of Myanmar of a major category of non-communicable diseases, cardiovascular disease, or CVD, and specifically address the value of investment into interventions in cardiovascular disease, namely screening, primary treatment for risk before an acute cardiovascular disease event, and secondary treatment following one of these events. Now, we refer to value of investment in our analysis model as quality of life years, or QALYs, specifically QALYs gained for investment into these interventions. And our final goal with this project is to make an investment case to government and donors for CVD intervention investment in Myanmar. Now, for our methods, we've been working to develop a cost-effectiveness analysis that aims to essentially compare a base case of interventions versus a case that indeed includes the different interventions that I mentioned earlier. We anticipated different forms of base cases where essentially nothing new is done, and intervention cases, which is demonstrated in our decision tree found in Figure 1. Each outcome of actual screening or treatment that we plan to consider and the relative weight that we plan to assign each of these outcomes in the decision tree is shown in the table next to Figure 1. And we base these figures and other parts of our model I'll get to in the 2014 STEPS Non-Communicable Diseases Risk Factor Report conducted during the country's transition to democracy. Now, with our base and intervention cases in mind, we worked on constructing a cohort or Markov transition state model. Now, taking a look at Figure 2, this essentially means that we work to consult literature and published reports from Burmese, Southeast Asian, and more global sources to estimate the probability of each of those little black and red arrows in the diagram, or transitioning from one of those states to another. And we also conducted literature, published reports, and in-country partners to obtain other values like costs, utility values, and risk reduction scores for medications if given treatment interventions. Now, once all of this was gathered and assembled on an Excel for 45 cycles or years for a hypothetical patient, we were able to obtain incremental cost effectiveness ratios, or ICERs, that compare the incremental raise in quality of life years for our chosen intervention case compared to our base case of doing nothing. Now, at this time, I would like to transition to a discussion and acknowledgement of some limitations of this model. Now, for some values, such as the relative risk reduction values and utility risk scores for cardiovascular disease events, these were sourced from non-national or even regional studies, and thus may not be wholly representative of Burmese health perception and outcomes due to lack of availability. Now, in addition, some cost data was simply difficult to obtain exact values for, as we experienced difficulties in getting this information due to COVID-19 outbreaks and civil unrest in Myanmar currently, due to the coup that occurred in the country in February 2021. And finally, I want to acknowledge that the data we had was simply not representative of every group in the multi-ethnic country, especially outside of the country's 8 major national ethnic races, especially those marked only as other. And surveying beyond the major ethnic group of Bamar was simply too limited to conduct a Markov model on this data alone. While we intend to conduct further work that attempts to adjust for these differences in some transitional probabilities and cost differences, as well as work to validate our model structure, one policy takeaway is the general systemic lack of consistent health data in large numbers for all in Myanmar, especially minority groups, and the need for further attention and equity on data collection on these groups. I would like to thank all those in the acknowledgements and those from the Margolis Center, CPIGH, and CPI for the support in the summer for this project. Please do not hesitate to contact me with any questions or concerns about this project. Thank you and have a great rest of your day.